Morning and welcome to the American Thoracic Society Sleep and Respiratory Neurobiology Assembly Journal Club. I'm Dr. Chana Chin, a sleep medicine pediatric pulmonologist at Children's Hospital Orange County, CHOP Children's in Orange, California, and I will be moderating today's session in conjunction with Dr. Erin Eschbach, my adult pulmonary and sleep medicine counterpart at the Yale School of Medicine. I would like to thank our listeners for joining us. Our journal article for discussion is on respiratory management of patients with neuromuscular weakness. This is an American College of Chest Physicians Clinical Practice Guideline and Expert Panel report published in August 2023. For today's discussion, we will review the recommendations and discuss the implementation of the guidelines by each of our respective teams and practices. With us, we have Dr. Serena Tsai, a sleep fellow at the Keck Hospital of the University of Southern California and Children's Hospital Los Angeles, who will be presenting today's article. We are extremely delighted to have our expert panelists with us today. In no particular order, we have Dr. Akram Khan, who is the first author of our publication today, Sleep Medicine Pulmonologist and Associate Professor of Medicine in the Division of Pulmonary and Critical Care Medicine. Oh, sorry, something just happened to my computer. In the Division of Pulmonary and Critical Care Medicine at the Oregon Health Science University School of Medicine, Dr. Reshma Amin, a sleep medicine pediatric pulmonologist and author of the publication and director of sleep medicine and long-term ventilation programs at the Hospital for Sick Children and professor in the Department of Pediatrics at the University of Toronto. Dr. MyMy Buu, a sleep medicine pediatric pulmonologist, pulmonary director of the Pediatric Neuromuscular Center at Stanford Medicine Children's Health, a clinical associate professor of pediatrics at Stanford University School of Medicine, Dr. Oscar Mayer, a pediatric pulmonologist, medical director of the Pulmonary Function Testing Laboratory at the Children's Hospital of Philadelphia and professor of clinical pediatrics at the Perelman School of Medicine at the University of Pennsylvania, Dr. Lisa Wolfe, a sleep medicine pulmonologist and author of the publication and professor of medicine in pulmonary and critical care at the Feinberg School of Medicine at Northwestern University, Dr. Peter Gay, a sleep medicine pulmonologist and author of the publication and professor of medicine in the Division of Pulmonary and Critical Care Medicine in the Department of Internal Medicine at Mayo Clinic. Our webinar will start with a presentation from Dr. Tsai. She will present the guidelines in sections, and we will pause at each section for discussion with our expert panelists. During Dr. Tsai's presentation, we will mute the other participants. We want this to be a lively discussion, so I encourage our audience to be involved. The audience can type in their questions in the chat, and I will read it to our panelists during the discussion. We will try to address all questions as time permits. Note that the session is being recorded. Without any further ado, I turn the floor to Dr. Tsai.
Hi, everyone. Good morning. My name is Serena Hsia. I'm one of the sleep fellow at the University of Southern California and Children's Hospital of LA. So today we're going to discuss the respiratory management of patients with neuromuscular disease. So respiratory failure is a significant concern in neuromuscular disease patients, and the CHEST guideline examined the literature on the respiratory management of patients with neuromuscular disease to provide an evidence-based recommendation. So there were 9 PICO questions that were examined, and to verify the certainty of evidence, grade approach was used to assess each outcome of interest, and it's divided down into high, moderate, low, or very low. And then based on the grade approach, the panel made recommendation using the CHEST grading system. So it's a combination of either strong or conditional recommendation, plus a high, moderate, or low quality evidence. And there's also ungraded consensus-based suggestion and good practice statement. So here's the table of all the PICO questions. So it includes the use of PFT, timing of PFT, testing for sleep disorder breathing, the use of non-invasive ventilations, respiratory parameters for initiating non-invasive ventilation, the different ventilation strategies, mouthpiece ventilation, invasive ventilation, and airway clearance technique. And we'll break it down into each individual questions in this presentation. So the first 2 questions that were discussed are the use and timing of pulmonary function testing So the panelists review the use of review the evidence to decide whether or not the use of PFT and other measurements of lung function parameters has any effect on the disease progression and patient preferences as an outcome. And further, they also looked at the timing of PFT for patients aged 6 years or older to see whether or not timing of the testing has any differences in outcome. So after reviewing the evidence, the panelists recommend that patients at high risk of respiratory complications, PFT is used to assess and to help with management decisions. And specifically, this is a good practice statement, and they use the force and slow vital capacity, the MIB and the MEP, and as well as the sniff nasal inspiratory pressure and the peak cough flow as part of the PFT. And in addition to that, they also recommend for patients with risk of respiratory failure, PFT at the minimum of every 6 months as appropriate to the course of specific neuromuscular disease. And this is a conditional recommendation. And then they also looked at the testing for sleep disorder breathing and whether or not testing for sleep disorder breathing has any difference in outcome in terms of the quality of life, symptom improvement, survival, etc. So the panel recommends that for symptomatic patients with normal PFT and overnight oximetry, consideration for polysonogram to assess whether or not non-invasive ventilation is clinically indicated. So they did see that there are observational study that shows ONO, in-lab PSG, and HSAT has moderate desirable effect to identify sleep disorder breathing, but there's really no data available on the frequency of each of these testing with respect to neuromuscular disease diagnosis. And there's limited evidence on transcutaneous end-tidal CO2, which can be helpful in detecting hypoventilation and to help initiating and managing the non-invasive ventilation. Then the panel also reviewed 2 more questions with the use of non-invasive ventilation and also the respiratory parameters for initiating the non-invasive ventilations. So whether or not the use or the not use of non-invasive ventilation has a difference with outcome in terms of survival, disease progression, quality of life, symptom improvements, and which respiratory and the use of different respiratory parameters to initiate non-invasive ventilations and whether or not that impacts survival and symptom improvement, etc. So the evidence for these is actually the desirable effect of non-invasive ventilation is moderate, but there is a net benefit to use non-invasive ventilation. And because the impact of respiratory failure on morbidity and mortality is pretty significant, the testing and timing of the non-invasive ventilation was really considered a priority. And even though, and especially because of the life-threatening nature of chronic respiratory failure, despite the low certainty of evidence, there is a strong recommendation to use non-invasive ventilation based on the GRADE guideline. The caveat is that a lot of these studies are predominantly done in older children and in adults with neuromuscular disease, and mostly are adults with ALS specifically. So the application to some of these studies to younger children with neuromuscular disease is uncertain. So the final recommendation after reviewing the literature for non-invasive ventilation and the initiation of it is that for patients with chronic respiratory failure, they do recommend non-invasive ventilation for treatment, and it is a strong recommendation. And to consider initiating non-invasive ventilation if your FVC is less than 80% with symptoms or less than 50% without symptoms, and MIB of -60 and MEP of less than 40, and the PCF of less than 270 liters per minute, and the SNP less than 60 in females and less than 70 in males is kind of criteria to start non-invasive ventilation. And for patients with sleep disorder breathing, they do recommend non-invasive ventilation for treatment, and this is a conditional recommendation. So in addition, they do use diagnostic testing like FVC, MIP, and MEP, ONO, and then whether or not there's sleep disorder breathing or hypoventilation on the PSG to help predict the timing of the non-invasive ventilation initiation. And I just listed the hypoventilation scoring criteria that was mentioned in the guidelines. So for adults, PCO2 of greater than or equal to 55 for over 10 minutes, or an increase in PCO2 of greater than or equal to 10 in comparison to awake to exceeding of 50 to over 10 minutes. And this is the pediatric guideline, which is the arterial PCO2 greater than or equal to 50 for 2% of the total time, and peripheral capillary oxygenation at less than 90% for 2% of the recording time as a criteria for hypoventilation scoring. So there's a very useful figure that was in the guidelines. So basically, it kind of outlines the recommendation that we went over. So the neuromuscular disease patient, first off, you do the PFT every 6 months to see if they met any of the PFT criteria to initiate non-invasives. And these are the criteria that I have described before. So the FVC criteria, the MIP and the MAP, PCF criteria, and the SNP criteria. And if the criteria are met, then you initiate the non-invasive ventilation. And if the criteria are not met, then you schedule follow-up PFT and you also monitor for symptom. And if there is symptom, then you go ahead and do an ONO or ABG testing. And the ONO and ABG testing criteria is also listed. And if the criteria are met, then we will initiate non-invasive ventilation. And if the criteria are not met, then to go ahead and perform a PSG to see if there's criteria to start non-invasive ventilation, and the PSG criteria is also listed. So overall, this is like I think it's a super useful chart in terms of the timing and the overall recommendation.
Great, thanks, Serena. So right now we'll pause to ask the panel's opinion and the author's opinion if they could speak onto their general workflow for the PFT criteria of this chart. So are people obtaining PFTs generally every 6 months? And if not, what obstacles do people encounter that prevent them from doing so? And which PFT tests are people looking for to obtain every 6 months? Or are they doing the full slew of tests that we encountered and discussed earlier?
I might start out here. Thank you for inviting us. I want to start out by giving a shout out to Akram Khan, whose tenacity made this thing come through after 6 years. We met at the ACCP in 2017 with 25 people, and you can see there's 13 authors now. So as they dropped off, he bulldogged his way through getting all of this done. So again, kudos to you, Akram, for keeping this herd of cats gathered enough to finish this. With respect to well, I'll tell you a little bit too about how this is situated. We grouped so as to not be too influential and perhaps having conflicts. For what I know for non-invasive ventilation, I was forbidden to contribute in the NIV section. So that's kooky things that go. And then with respect to the bibliography, I want to make sure the group understands that there's some really good things in there that you will never see in the guidelines because it doesn't address what is there in the PICO question. For example, the PFTs, we're talking about the timing of this. There's a lot of prognostic information in there, and you're not going to get it unless you go to the article and actually read this stuff. So just to briefly say before I turn it over to my colleagues, no single PFT parameter predominates in the predictive value of the survival, but most of us who treat know that the maximal respiratory pressures are first, the vital capacity probably follows next, and then the oximetry is kind of the last to go. And that all of these things that are recommended are make perfect sense clinically, but unfortunately, this country is constrained by your ability to get equipment based on what these urologists and physical therapists who run Medicare decide. So the people who have early disease don't have access to this unless, of course, Lisa and I and the people on the technical expert panel succeed with our submission that has gone forth to Medicare, that maybe some of these guidelines will change in the future. So I'll stop there and let my colleagues take it from there. But again, thanks, Akram.
Yeah, Lisa.
Yes. So can I comment on extend what Peter said? There's a couple of things. One is, remember that this is a global look at neuromuscular disease. It's not for any specific disease, although yes, most of the data comes in adults from ALS. But we know that specifically some diseases like rapidly progressive ALS, V4B mutations, et cetera, they're going to need spirometry more frequently. And then if you compare this to, say, a boy with Becker's who is very stable, especially over the age of 20, 6 months is, maybe a little aggressive. They're probably okay with once a year. And so I think that there's still going to need to be the doctor at the bedside making the judgment call on this. The other thing is, yeah, we're bound by the data, and exactly what Dr. Gay just said. You're going to see on here recommendations for SNP testing. Medicare will only accept MIP testing. So you're going to have to take all of this with a grain of salt.
Yeah. And Reshma, you want to talk about pediatric considerations? Lisa had brought it up a little.
Yeah, sure. Thanks. So I think the reason we were so inclusive with listing all of those different PFT criteria is that it's hard to know which is the best one to go to, but also we're trying to be just quite pragmatic because different pediatric, different adult programs, different places sort of in North America, across the world, are going to have varying access to those different types. I think just the pediatric specific considerations are that number one, we don't really have great normative data for MIPS and MEPS in pediatrics. And so using the cutoff of, the adult cutoffs of 60 and 40 might make sense for our 12-plus-year-olds, but they're not going to make a lot of sense for the younger kids. Similarly, for the peak cough lows, we snuck it in there because it's important to remember for pediatrics that the peak cough low cutoff for less than 270 is specifically for 12 and above, but there's nice normative data for younger children, and then there you use the less than 5th percentile. Similarly, I think that SNP testing, if you have it available to your lab, is helpful. But again, the normative data is limited, so it is hard to know exactly what the cutoff is specifically to use for that.
Yeah. And I'll add 2 points that were brought up earlier. And one was that as we talked, there were some people who felt that ALS patients should have PFT testing every 2 months, and just depending upon the rate of progression. So we came up on this 6-month consensus based upon the wide spectrum of illnesses you're seeing. And as Lisa and Peter were pointing out, you have to go with the rate of progression of your patient's illness. 2, Lisa had very nicely pointed out to us when we are making this guideline is that we want to start NIV early. So we have that if you have FVC less than 80% and you are having symptoms which we listed out in this figure, you should consider early NIV. I'll stop here. I think there is at least one hand up for questions.
I'll add another pediatric voice. I find MIP and MEP to be exceptionally frustrating to use in pediatrics because of the high variability. And I've focused primarily on vital capacity at 50 as being a reason to get either a capnography study or a polysomnogram as an intervening step before determining when to start non-invasive ventilation.
Great.
Mihaela?
Yes, thank you all for organizing this excellent work. Kudos to all. One comment, which one way to use spirometry, and in the adult world, I use it quite often that way, is that actually because the Medicare does not specify the position that spirometry has to be obtained under, I use supine spirometry to get a more severe FVC picture sometimes if you know the parameter. Have they changed that, or these are
So Mihaela, I agree with you. I think supine testing is the correct testing. We do it for every patient, every visit.
Right.
Right, but there are 2 limitations. One is that the vast majority of patients are getting their spirometry done not in the office, but in a PFT lab. And if the PFT lab, as standard, is using a body box to run their spiro in, they can't lay them flat. And then the other problem is that if the patient is so disabled that they can't get up and get on a table to lay down, it becomes very limiting. And then the third thing is that most of these patients are cared for by a neurologist without a pulmonologist involved. And so we feel that we are not getting adequate testing. The number one test a neurologist does is an upright FVC as a single measurement, and they're not looking at anything else. And that's one of the reasons why the ERS, the Canadian Thoracic Society, and the French Thoracic Society now all recommend 80% with symptoms, because it's dealing with the reality on the ground of the challenges with getting supine values.
Yeah, I actually learned this from a neuromuscular district. So I use that. Then a question for the group: are there any studies looking at combined sort of technology? Because sometimes we face these borderline nocturnal oximetries, an ABG that shows a CO2, 45 at 2 p.m., obtained at 2 p.m. What's the utility? And the sleep apnea, symptoms are questionable, particularly in these patients who all of them are going to be fatigued under Medicare. That could be a problem. So what's the recommendation for conducting the PSG in these kind of borderline situations where you would hope that you pick up hypoventilation?
So if I understand your question, adding ABGs or some kind of blood gas measurement to all of this, in my mind, would be a later discovery, that by the time they're hypercapnic, which is what we're so disappointed in the US coverage guidelines, and why the Europeans see much brighter than us, that symptomatic and mild change in the FVC and patient early on getting used to the device to see what symptomatic benefit they may receive would certainly be desirable. I will give a shout out to the technical expert panel recommendation being reviewed presently by the local coverage determination commissar. And if indeed that comes through soon or early next year, we will be able to consider that. But a blood gas change is a late discovery. Again, probably, as we said, whatever the patient can do best, and maybe that's an SBC, and watch that progression is probably what you should choose for your patient.
Great, thank you. That kind of goes into my next question about what limitations we are seeing based on these PFT criteria in getting these devices covered for our patients. And I know we had mentioned perhaps doing a supine spirometry, which may be a choice for some, but what are some other obstacles that we're facing in terms of getting this covered? And maybe you can provide an update as to what changes are on the horizon.
Well, can I make some comments about real life application of these guidelines? I actually really appreciate that the authors are very inclusive to have all these different variables to consider, because historically, if you need to show hypoventilation, then it's in pediatrics, especially, it may be too late, because we know that these diseases progress. We want to start non-invasive ventilation early. And so I really appreciate that the thresholds that were put into this guideline was actually pretty potentially low, so it can be more inclusive and more useful. Although I actually haven't seen this into fruition yet to include this in my letters of medical necessity, in my clinical documentation to get devices. I think fortunately in my state, a lot of the patients are on public payer for these devices, and for the state of California, with the clinical expertise, the right documentation, we are able to justify. But to my colleagues who are not as potentially experienced or savvy or have enough volume, I think that this type of paper can really support can be used to support early initiation of NIV. And I look forward to hearing about this technical panel on how we can lower the bar for payers to pay for these devices for our patients.
Dr. Meyer, did you have a comment?
Yeah, I have a general flow question. I think there's a pretty significant practice difference, not passing any judgment, just a practice difference in terms of flow between pediatrics and adults. That may be because of the practicality of getting polysomnograms, but we're fairly restricted and required, at least among the payers that we deal with, in having nocturnal hypoventilation or gas exchange abnormality before getting non-invasive ventilation. And we've never been successful in arguing for it just based on spirometry or MIP and MEP.
What's most disappointing to clinicians who, as we gather at national meetings, discover that I don't get what you get, and there's a lot of regional coverage variation that drives people nuts, is a policy wonk trying to explain the vicissitudes of that variation. I fall flat on my face. I can only say that for the question about where we are, watch to see for the announcement of some kind of coverage decision that we hope comes, and there'll be a comment period for all of you to voice your concerns, and I urge you to do so on the CMS website. But at this point, early treatment is going to be governed by what you understand about reimbursement and the capabilities in your area.
But effectively, what we're saying is that a vital capacity below 50, if I got this right, a MIP or MEP below 60 or a MIP below 40 is a surrogate for hypoventilation, meaning you need to be on ventilatory support. And I guess the frustration is that, wherever that was defined, I presume in the ALS literature, that really hasn't pervaded into the pediatric literature. And so we have to demonstrate nocturnal hypoventilation as opposed to a surrogate measure. And I don't know that I have a problem with that so much. I just find the practice difference between pediatrics and adults a little perplexing.
Yeah, just to, not to make you feel bad, but in Minnesota, it's just the opposite. I mean, kids here get just about anything you ask for. So
Yeah.
we're not held to those standards.
Thanks for the comments. I think for the purpose of time, maybe we'll move on unless someone else had something quick they wanted to say.
I think we had one question from the audience from Todd Luston, so let's let him answer.
Yeah, hi all. Thank you. Excellent discussion, and the question was actually at least initially responded to by Dr. Kay, but I was just interested in the panel's perspective on this. Given the patient population and the difficulties patients have potentially with the FVC maneuver, so I work for a company that offers digital solutions that we, are looking across the research space with multiple sites who may have variable abilities to conduct spirometry with variable abilities presented by the patients as well. And are there any concerns about making a more blanket recommendation to utilize SVC rather than FVC in these patient populations? Any downside that anyone can think of that would preclude offering that recommendation in this patient population for clinical research, given the variability presented by various sites and various operators? Any thoughts on that?
Lisa, why don't you jump in? I can see you're eager to do so. Can't hear you, Lisa.
Lisa, you're muted.
Sorry about that. So what I would tell you is the SVC has been really pushed in the area of drug studies, especially in ALS, because it's more reliable in patients with bulbar dysfunction. The forced vital capacity is super difficult in that realm. And so we do think that it's going to be accepted by the FDA because of the number of studies with ALS specifically. The problem is a performance and access issue in that most most PFT labs are not routinely doing SVC. So I do think that it's going to be the way to go first under the FDA and for drug trials, and it's going to take longer to get it to Medicare.
Got it. Thank you. We're struggling a bit as to whether to make it a general blanket recommendation in this space, but for the great reasons you indicate, but certainly, a protocol-driven approach would allow for it. And obviously the bulbar circumstance with the ALS is driving the situation, but they're with the full range of neurologic deficits, we can see more and more of this. So thank you very much. Appreciate it.
So for me in my practice, I do prefer to use SVC because it's less fatiguing than the FVC maneuver. But the interesting thing is because many of the patients that I see are also in other clinical trials or observational trials where they want the FVC measure. So I actually do my order of testing as SVC, either MIP, MEP, SNP, peak cough low, then FVC last. But I do all that is available. And it did take education of our respiratory therapists, but the actual devices we use were no different because the spirometer is capable of SVC and FVC.
Thank you.
I do have a question about a gas exchange. I don't know if the group had addressed this question, and I'm aware of the pathophysiology and the importance of progression in pulmonary function. But apart from that, has often, for raising even the suspicion, at least in pulmonary clinics I've seen, apart from sleep clinics, among only purely my pulmonary colleagues, is there any importance of the timing when the ABG is done? Has that been emphasized in this guideline? Because it's a different thing, in my opinion, particularly when you are on the edge in terms of pulmonary function. Whether the blood gas is done at 2, 3 p.m. in the afternoon when they show up in clinic, and you rely on that potentially for qualification, versus in the morning. Is this timing specified in the guideline, or is it important or not? And second, another question. Just like in obesity, hypoventilation, any value for serum Vicar?
Again, it kind of depends on what your goal is. I mean, if you're really trying to get a device, if you're making an effort to play the game and get your patient equipment, then you make that target decision first. And I'm very Machiavellian about this. However you get to Rome is okay with me. If you call it a vital capacity, it turns out it's an SVC, and Medicare doesn't really see that it's not an FVC, well, God bless you. If you get a blood gas just when they wake up and they're still hypoventilating from the night, and they just make a 45, all power to you. But you just figure out what your goal is. If your decision is that this patient needs NIV now, and you're right on the cusp, then you're going to have to be clever. I call them sneaky Pete rules. We get there however we can.
All right, thank you, everyone. I think for the purposes of time, we still have a lot to get through for the article. So let's move on, Serena.
All right. So the next set of discussion, the PICO question is on non-invasive ventilation strategies and mouthpiece ventilation. So for non-invasive ventilation strategies, the panel looked at different methods, different strategies of non-invasives and whether or not it impacts survival, symptom improvement, etc. And for the mouthpiece ventilation, the panel looks at mouthpiece ventilation in comparison to other non-invasive ventilation methods like face masks, helmets, and so on and so forth to see if there's any difference in outcome. So the recommendation is that for patients requiring non-invasive ventilations, individualized non-invasive ventilation treatment to achieve the ventilation goals is recommended. So it depends on the several factors: the comfort of the patient, sleep quality, whether or not there's leak, oximetry, and secretion management. But overall, there's no strong evidence for one method of non-invasive ventilation over the other. But there is that the backup rate achieves better synchrony and can improve gas exchange. And then in terms of the mouthpiece ventilation, for patients with preserved bulbar function using non-invasive ventilation, mouthpiece ventilation for daytime ventilatory support as an adjunct to nocturnal mask non-invasive ventilation is recommended, and it's a conditional recommendation. But the limitation is that if patients have progressive bulbar symptoms, it could limit the use of this option. But so overall, the desirable effect of mouthpiece ventilation are unknown, but there could potentially be delay or avoiding the trach, as well as improve speech, cough, and coordination of breathing and swallowing. And then the panel also looked at the use of mechanical ventilation and whether or not invasive home ventilator strategies through a tracheostomy in comparison to other strategies like non-invasives has any effect on outcome. So the recommendation is that for patients who non-invasive ventilation fails or who are intolerant of them, so that includes people who have worsening bulbar function, frequent aspiration, insufficient cough, episodes of chest infections, despite adequate secretion management or declining lung function, invasive home mechanical ventilation through a tracheostomy is an alternative to non-invasive ventilation. It is associated with a higher cost and some caretaker burden in comparison to the non-invasives, and there's really no consensus on when to start mechanical ventilations. So both non-invasive and invasive ventilations should be considered as an acceptable options just based on patient preference, ability to maintain a mouthpiece, and also other available resources. So again, there's the algorithm in figure 2 of the guideline that kind of outlines the overall recommendation is that patient who's receiving non-invasives, whether BiPAP, and they look at whether or not they're experiencing any of these that we mentioned above, worsening bulbar function, aspiration, frequent cough, etc. And if there is, and then the patient's willing to do tracheostomy, then can start invasive ventilation through a tracheostomy, and if they're not, then they with a close clinical follow-up.
So for our panelists, this is addressed towards you now. So we understand that there is no consensus statement from transition to non-invasive to mechanical ventilation, and it's dependent on your patient's goals and the local expertise. But we did want to get an idea about your center's preferences. For example, ours, once you move to 24 hours non-invasive, we will strongly encourage invasive ventilation if it's in line with the patient's care goals, unless they're going towards palliative. So is that similar with your practice?
At our center, it's maybe around 18 hours, so very close to you. Lisa, you're muted again.
Sorry about that, guys. I hear what you're saying in terms of the importance of having the goals of care conversation first. And one of the really important things that we didn't put in here, because there's not really data about it, is the fact that in the US, 90% of patients with ALS will choose to go through a hospice palliative care route and choose not to do tracheostomy mechanical ventilation. And the other part to that is that in adults, there is no insurance provided care in the home where there is in pediatrics. So again, we're going to see a huge difference here between pediatric practices and adult practices based on the availability of care.
I'm of the same vein, and let's get our language correct here. So NIV can be delivered with a BiPAP, or as Medicare will call it, a RAD, and also a home mechanical ventilator. The home mechanical ventilator is the only one that can provide the SIP addition there. And in some areas, not all, I would guess Dr. Meyer could never do this. You can get 2 ventilators. You can mount one on the portable device that gets them out of the house. It's a wonderful adjunct with a SIP ventilator, and have another one in the home. We can do that in Minnesota, but that's rare for other parts of the country. But
We actually, I'm sorry.
go ahead. I'm interested in your area.
Yeah, we routinely, for patients who are on continuous ventilation, we routinely get a primary and a backup ventilator. That's not a problem at all. The one thing that I do think is different between pediatrics and adults is most of our progressive pediatric neuromuscular disease has bulbar dysfunction as a very late finding, probably very much in line with when we transitioned them over to the care of an adult provider. And so for me, in my practice at least,
And
we
thanks
rarely,
a lot for that, Hank.
Yeah, well, we're trying to keep you guys busy. Transition medicine is a expanding field, but we largely we largely make this at least my group largely makes it a quality of life and a patient/parental preference discussion, because there's so many wonderful ways of being able to provide mouthpiece ventilation, and with the wide range of nasal interfaces, have even somebody that's not able to or interested in doing mouthpiece ventilation alternate between nasal interfaces.
Yeah, my comment would be that transition from non-invasive to invasive ventilation isn't about the number of hours needed for support. It's about, can you deliver adequate respiratory support non-invasively or not? And so typically, because of the things alluded to, cost of care, complications associated with invasive ventilation, so not the device, but the actual tracheostomy, we do support families who want to go toward non-invasive ventilation 24 hours a day. That's not considered. Time on ventilation is not a barrier and not a criteria to say you have to have a trach. So that's our practice here at Stanford.
Well, we're of the mindset that you don't provide tracheostomy to a patient, you provide it to a family. So the understanding that you're embarking upon a lifestyle change for an entire support group, that's where the discussion really comes. And I face these deal breakers where, oh, we can't do it at home anymore. You have to go somewhere else. The deal breaker is right there, leaving the home. So that'll never happen to get to tracheostomy. That's often a barrier for us.
Yeah. And for us, there are no ventilator facilities in the state of Oregon. So you have to be in a foster home that's willing to take a ventilator, or you are at home.
And also, there's the issue with locked in. So, the neuromuscular disease progresses even after the trach and vent is placed. And the question is, once the patient's locked in, they lose autonomy, and decision-making for post-locked in needs to be made pre-locked in. And physicians don't usually talk about it, and that's a big problem.
The other challenge that we run into is that in pediatrics, unlike in adult medicine, critical care and pulmonology is almost exclusively separate. And so we end up playing defense a lot of times on the well-intentioned but somewhat misguided, very direct recommendation that a patient, with SMA 14 and has a pneumonia should just get a trach. And so I think we've been able to, kind of prevent that and educate some of our colleagues. But I think you in adult medicine, since you have everything together, I would hope are able to not have to deal with that.
Since we're talking about non-invasive ventilation, are you utilizing different modalities too, like IVAPs or AVAPs as a preference, or just straight BiPAP? And since you are utilizing daytime ventilation, are you using different monitors during the daytime to set those, or are you just basing it off the sleep studies overnight?
So I can speak a little bit about pediatrics. So I mean, our neuromuscular patients, often we use a lot of IVAPs. We use a lot of, just because we did a study, several years ago now, where we compared sort of neuromuscular patients on ST mode versus IVAPs mode, and actually showed that adherence was better with the IVAPs mode, but the rate limiting step is really just managing the leak up front first. the advantage of IVAPs is that then over time you get a bit of a self-titration. So if you can't get them back into clinic or back into the lab, and they do have a progressive change in their respiratory status, if things go sort of according to plan, then at least you're able to sort of have some interim titration and management. But again, the rate limiting step is just being able to deal with the leak, because if you don't deal with your leak, then the rest of your IVAPs is really not going to be successful. That's probably the other mode that we use. In terms of daytime, we do sometimes some clinic starts where we'll be doing an air trial and initiating some baseline settings before we put them in the lab. Many pediatric programs, not ours is sort of just through like a research study right now. Many pediatric programs, just because they don't have access to full PSG, will be actually doing like clinic starts and then following them with like oximetry and ventilator downloads, and sometimes integrated oximetry with the ventilator downloads. So that is happening in some pediatric programs.
And then just one comment altogether, which is that our group did look to see if we could show that there was a specific mode that could be recommended over any other mode. The problem is there's not enough data, and there's no RCTs that are head-to-head trials that we could actually say this mode is the best or that mode is the best, which is why the other thing is really going to be local expertise more than anything else. Our group sort of had their hands tied.
We
I
designed
find
a
the best
protocol.
mode is the one that works.
Yeah, we developed a protocol that for neuromuscular disease, we do a split night study when they meet the criteria that they're going to get coverage for it and are symptomatic and would benefit in our minds. So we split it into a bilevel PAP and a AVAPS protocol so that the patient is exposed to both in the same night. And then we try to achieve the same goals. And in the morning, we actually ask them their preference. We published this in Journal of Clinical Sleep Medicine, and it's not in the guideline because it wasn't part of the discussion there. But ultimately, if you look at what the patient preference is, first of all, most of them can't tell a difference. Second of all, there's a pretty even decision process of the ones that did have a preference. It's a break even. And then it came down to, well, are they going to, I got to be careful about this. Are they going to go in an area of less expertise? So I won't name a state. Or are they going to be in an area where the respiratory therapists are adept at this and can handle the alarms or difficulties that you'll get into with an AVAPS that you just don't get into with a bilevel with a backup rate. So that's how we do
it. And just one other thing real quick. There are two ongoing large RCTs. One is the Denham trial by the NHS, and that's going to focus on patients with ALS. And then Dave Berlowitz's trial through the Royal Melbourne, which is also going to look at patients with ALS, randomizing them to in-lab versus home starts.
All right. Just in the interest of time, I will open up the panel or the floor to Dr. Hsia again to continue the presentation.
All right. Lastly, the panel looked at airway clearance techniques and secretion management. So for the airway clearance techniques, they looked at selective airway clearance technique and whether or not there's a difference in outcome in terms of secretion management, survival symptom, length, quality of life, etc. So the secretion management includes a couple strategies: anticholinergic medication, Botox therapy to the salivary gland and salivary gland radiation therapy. And then the certainty of evidence was low to very low on all these interventions. And there's a very nice table kind of describe each of the therapy and the pros and cons. So for the anticholinergic medication, it's actually an initial, it's recommended as kind of a first-line initial trial, and it's inexpensive. And to use if the benefit are greater than the side effects. And there are some more expensive and longer acting medications for that can be used as well. In terms of the Botox therapy to the salivary gland, the data are limited and the doses are not very well defined. So it's inexpensive and does have good long-lasting beneficial effects, but it may need to be repeated, and it can be associated with viscous saliva with a little bit with also pain. And then salivary gland radiation therapy has limited data and does not define. Doses are not defined, and it has long-lasting relief. However, it is associated with irreversible dryness. So the panel had recommended a therapeutic trial of anticholinergic medication as a first-line therapy, and to continue if the benefit are perceived to outweigh the potential side effects. And if the anticholinergic medications response are inadequate or patients are intolerant, then the use of Botox and salivary gland radiation therapy can be considered. Then they also looked at different airway clearance technique, which includes glossopharyngeal breathing, includes cough assist device, manually assisted cough, the LVR, the lung volume recruitment by air stacking, and then the high frequency chest wall oscillation. And all of these can improve lung function and reduce morbidity. And a combination of therapies can be better, may achieve outcome better, but there's no data that really shows superiority of one specific airway clearance strategy. So, and again, there's a really nice table that kind of describes the each of the technique and the indication, as well as the pros and cons. So for the glossopharyngeal breathing, it's indicated for patients with hypoventilation. It is low cost and the patient can perform independently. And in terms of the manually assisted cough, it is indicated for patients who have reduced cough effectiveness. It's low cost, but it does require caregiver assistance. And the lung volume recruitment strategy, like the breath stacking technique, it is used for reduced lung function or cough effectiveness. It does require caregiver assistance. The cough assist device is used for reduced cough effectiveness. That's not improved with other techniques. It is a little bit more expensive. It requires caregiver assistance. It does reduce morbidity and hospitalization, but it can have procedural intolerance. And same thing with the high frequency chest wall oscillation therapy. It is indicated for patients with difficulty with secretion clearance. It's a little bit more expensive, some of the devices, and can have some procedural intolerance as well as require caregiver assistance. So overall, the recommendation is to consider glossopharyngeal breathing for lung volume recruitment and airway clearance for patients with neuromuscular disease and hypoventilation. And then for those patients who have reduced cough effectiveness, manually assisted cough technique can be used independently or added on to other modalities. In the patients with reduced lung function or cough effectiveness, the breath stacking method using a handheld resuscitation bag or mouthpiece can be used. And patients with reduced cough effectiveness, which cannot be adequately improved with alternative treatment, you can use a cough assist device. And then for those with difficulty with secretion, then the high frequency chest wall oscillation for secretion mobilization plus other airway clearance therapies can be used. And I think that's the last slide.
So question for the panel and the group, how are you all incorporating teaching of these non-invasive airway techniques into your clinical practice? Do you have resources such as respiratory therapy help or any online tools that you can share with the group?
The best online teaching is the CanVent curriculum, which is available through the CanVent website and through YouTube. And this is the curriculum that was developed by Doug McKim at the Ottawa Rehab. It's hands down best thing out there.
We had the opportunity to send our physiotherapist to Doug for a few days to learn all of his tricks of the trade. And we now have him descend into a room of somebody that we need to start on non-invasive on airway clearance, and it's been very successful. I did have one question, if I can just throw it out there. I've been not a very big fan of using high frequency chest wall oscillation, in part because it requires another set of approvals, which can be a little bit of a challenge and favor the cough assist over it. I was very curious to find what others' experience has been.
So as far as the chest wall oscillator, I find that when you give it to someone older and frailer, they don't mind turning it up to massage level percussion. When you turn it up to effective percussion, the shake and bake just doesn't, go comfortably. So they often opt for a different cough assist device. Remember, Medicare gives you one. You only get a choice of one or the other. So choosing one that's effective is kind of what you're stuck with.
So
that is similar between adult and pulmonary and pediatrics.
Yeah, I'm just gonna throw two things out there in defense. One is that in ALS patients specifically, they can get one device while they're on their standard insurance, and then when they switch to Medicare, they can get a second. So there is a workaround. But the other thing is, for those of you who have seen Tina Anderson's work with the use of cough assist in those with severe bulbar disease, you can see that the cough assist fails them because of profound collapse of the posterior pharynx in response to the pressure that's provided through the cough assist. And in those patients with really severe bulbar disease that have constant microaspiration and aren't going to tolerate a cough assist, there is still a role for therapy vest. And so there's an institutional database that Noah Litzen and I had access to several years ago that showed that if we do give therapy vests to patients who have had hospitalizations with neuromuscular disease, we can reduce hospitalizations. So there is a role, it's just picking it for the right patient.
And I think from a pediatric perspective and a Canadian perspective, so we have government access to cough assist devices. We don't have any access to vests, so vests would be out of pocket or private insurance cost. And I think the second thing is that also in Canada we had the E70, the Respiratory E70, which actually has an oscillation feature. And I understood that in the US you guys have a T70, which doesn't have an oscillation feature.
Reshma, they're not making them anymore.
Yes, and so
nobody has access to it.
Yes.
Unless you can find one that's old and fell off a truck.
Yeah, so we still, so I mean that now there's, for new starts, that's the issue. They're all getting a different device, but historically that's sort of up till this date. That's why we've really just used the cough assist device, not incorporated the vest.
Do the byways and the Sinclair not have an oscillation feature?
They do. They both do.
They do.
Yeah, and if you go with the Voxen, it's available with that cough assist as well.
Did you guys have any discussion around interpulmonary percussive ventilation when you were putting this together?
We did not, because there was not enough data available to review.
Yeah, exactly. I just asked because that's been my preferred adjunctive airway clearance device, because you can nebulize, hypertension saline should you want, or something else.
Getting that prescribed outside of the hospital is an act of Congress.
We've been a little successful. It is very difficult.
Well, we've hit our 11 o'clock time now, so sorry if we didn't get into everybody's questions, but I wanted to thank our panelists, Dr. Akram Khan, Reshma Amin, MyMy Buu, Oscar Mayer, Lisa Wolfe, and Peter Gay, and our presenters, Erin Eschbach, and our board members, Dr. Iris Perez at CHLA, and Erin Eschbach, my co-moderator. And I'd like to thank everybody for a very stimulating discussion, and a big thank you to our listeners who took the time to join us today. And I hope to get this session posted up soon on the ATS SRN website in the Journal Club section. So I hope everybody had a chance to enjoy this session, and apologize to the comments we didn't get to. We will try at the next sessions.
Thank you.
Thank you all.
Thank you.